So today I will try to continue a little bit on pressure loading. There are a couple of topics that we haven't covered and that I think are relevant when we look at this. Advance, yeah. Okay, maybe let's come back to the force development, because with the loading, this is something which is really important there, because last time I told you that there's like different mechanisms at which the heart can compensate for loading increase, whether it's either an acute or a chronic loading increase. So the acute, where one of the things that you do is you can change your sphericity, of course, in order to regionally lower the wall stresses. And chronically, obviously, you can both increase the thickness by myocyte hypertrophy, and at the same time, of course, have more contractile force development available because you have more contractile material. And then at the same time also, if your wall gets thicker and you do it in such a way that the endocardium moves inward, or you decrease the size of the cavity, and you then also lower, again, the wall stresses. Now, what I also mentioned at some point in the beginning is like that the timing of the force development is actually quite important. So because force development is starting at the moment that you have electrical activation of the myocytes, and so then your contractile material is, or your contractile elements are starting to cycle in a way that you get cross-bridge binding between your actin and your myosin. So your force development is starting immediately. Then when the pressure is high enough, of course, you get opening of the valve, and then you start to have shortening. But the shortening, so the force development, as I said before, is actually finishing or diminishing rather early within the cycle. And the reason for this is that what we need to do is we need to have time to break down the cross bridges and be able to make sure that we are as elastic as possible for the relaxation. So that means that when you look at the ventricle as a whole, what you have is the force builds up, you start the ejection, then the force goes down, but of course, due to inertia, you still have the ejection going on. So, and it's only then, even if the pressure at that moment can become lower in the ventricle with regard to the aorta, it's only, of course, when also your inertia forces are stopping, which means that when effectively your blood velocity becomes zero through the valve, then the valve closes. And so it's not only the pressure difference, of course, but it's also the kind of continuous motion of the blood that is going there. And so that means that in reality, in a normal ventricle, force development is early. You start the ejection, then the force development stops or diminishes while the tissue prepares for the next kind of filling phase. And in the meantime, you still have a little bit of ejection going on. And this means that, of course, your early diastole, so your early filling, is most efficient, because then your tissue is as elastic as possible. Because keep in mind also that during the contraction, so if you have tissue, so when the tissue contracts, as we said, you have to deform it. But of course, also, since it's an elastic material which is non-compressible, you can see also that part of the energy is being used to load this tissue as a spring in some ways. So what you do is you kind of contract the tissue. So that means that then when the valve closes, what you then get is, of course, it springs back. And this is how early filling is taking place. So this is efficient in a lot of ways. So it's efficient in the sense that when your force development goes down early on, you have the time to break down your cross bridges, because that is the thing that takes time. And also that's the thing that on the cellular level that consumes energy. So it's not the contraction that consumes energy, but it's really the relaxation. So the breakdown of the cross bridges, that's what uses ATP. So that means that it needs a certain time, of course. So there you prepare, and then you have the most efficient early diastole also. So it's this whole combination why we have this early force development. Now, the nice thing of this is also is that, first of all, this is the most efficient way to do it, given the contractile material that we have, and given the way that the tissue is doing the contraction and the relaxation. But on the other hand, it also gives us more flexibility. And you can see that here nicely in this curve. So these are calculations of active force development that's based on kind of imaging with some modeling, because of course you cannot measure directly active force development, but you can measure deformation and pressures invasively. And from that, you can use a model in order to do it. So in that sense, it's model based, but it's quite accurate actually. So what you see here is in this greenish, you see the normal force development, as I said before. So force development goes up at the moment that your electrical activation is done. And then you see that it rapidly decreases, so that in the second half of your ejection, you virtually have no force development anymore, right? Which is also what I said last time. You probably need less force development, because when the cavity becomes smaller, of course, your wall stresses also become smaller in the Laplace way. So in that sense, it's also, even because of this, you don't need these high forces. So everything comes together that this is in a nice way. Now, what happens if we have an acute afterload? So say that you would constrict the aorta. What now happens is, of course, the force development or the pressure needs to be increased, and you would need a lot more energy in total. So you need a lot more power in order to displace the blood at this higher pressure. So you need to find a way to improve this. Now, obviously, given the myocytes that you have, there's almost no way acutely to increase your force development, because you just don't have the contractile material to do it. But what you can do is you can change the timing. So what you actually can do is, instead of already decreasing the force development very early on, what you can do is you can actually keep on developing force for a much longer period, so that in total, the area under this curve, that's like the power that is being developed, can increase without having an increase of the force development itself. So what's now happening is that instead of that you get this kind of force development and then this inertial continuation of the blood flow, what happens is that actually force development keeps on going on. Of course, the ejection will be slower in total. So you will see that your velocities might decrease and your deformation, or especially your rate of deformation, might decrease. But you can actually keep on developing much, much longer force in order to kind of eject against a much higher pressure without failing. So you still can generate the stroke volume that you need by using this kind of mechanism. So this is an acute mechanism that could change from beat to beat. So immediately in the next beat, you can do this. And this is partially also because when you look at what arranges the amount of force being developed, is related again to your contractile material, and is related to the length of the overlap in some ways. So if you would contract slower, you can actually effectively also keep on doing force development longer. So the advantage is that this way you can cope with an acute loading. The disadvantage now is, of course, that in the end of the cycle, at the moment that you should go into your diastole, in your filling phase, what you do is you still have your cross bridges bound there, because you're still actively developing force. So that means that now, at the one hand, your tissue is much stiffer. So it's functionally much stiffer, because the tissue with bound cross bridges is much stiffer mechanically than when they're loose. So that means that there's not much of a spring effect in order to do the early relaxation and the early filling. And additionally, also, you will need the time in order to break down these cross bridges, because you still need to break them down in order to be able to relax. So that means that, first of all, your isovolumic relaxation period will increase because you just need time in order to do this. Plus also your early velocity, so your early filling phase, will be much, much, much slower, because you are still stiffer at the moment that you need to relax. So that means that you can deal with the pressure loading, but you're partially compromising the early filling. We'll come back to that in a session when we start talking about filling and diastolic function and things like that. But this is something typically that you see is like when you look at patients with pressure overload, typically hypertensive patients, what they say is that they always get early diastolic abnormalities. And in a lot of papers, this has been attributed to, for example, already tissue changes, so fibrosis of the tissue and things like that. But you don't really need that in order to get an abnormality, because if you have relaxation abnormality, as they say, so you have like this slower relaxation because of the fact that you actually continue to contract or at least develop force much longer, you will see that that already gives this early diastolic changes. Right? So advantage, you can cope with the loading acutely without failing. Disadvantage is that you are less well prepared to do the filling for then the next ejection. Now, obviously, if this is chronic, so that means that if you have an increase in loading, which is for a long time, for example, a developing aortic stenosis, what you know there is that now, of course, you get hypertrophy, as we said before. So you get effectively more contractile material. So you are able to increase your force development. So that's what you see here. So you can really increase your force development, and in this way, increase the power that you develop, so the area under the curve. And you can actually combine these mechanisms in some ways. You see here, this is effectively from a patient with an aortic stenosis. And what you see there is that obviously force development is much higher. And what you see also is that actually the peaking is later within the cycle, although it's not as long as what happens in the acute loading. So you're using these two mechanisms. One is the chronic adaptation, where you need to get hypertrophy. And of course, in order to get hypertrophy, that takes a long time, and that takes months. So you need to find this balance between the increase in your loading. If you have an aortic stenosis, for example, it mostly will continue to become smaller and smaller over time. So, and you need to keep on compensating for this. So that means that in the end, you probably find a balance between these two compensations. So the chronic compensation, which is really increasing the force development, and the acute compensation, which is looking at the temporal dynamics of the force development, where you can cope with it, but at the cost of less efficient relaxation next time. Now, this is in a way theoretically, so that is theoretically, that's kind of physiology. The question is whether there's ways to look at this in clinical practice or find relatively easy signs in order to do this. And the thing is, when you start thinking about it, and you start thinking what I said before, is like that you have this inertial component in some ways. So when you would look at how the blood is being pushed out of the ventricle, that will tell you something about how, of course, the force development is taking place within the whole ventricle. Because what you will see is like, as long as there's active force development, what of course you get acceleration. So Newton's law says force development, so you get acceleration of the blood. If you decrease your force development, of course, you get deceleration up to the point that it's zero, and then the valve closes. So that means that if you look at the dynamics of acceleration and deceleration of the blood, it actually has some inference on the force that is used in order to do it. At least force in brackets, the difference between your ventricular pressure and your aortic pressure. So, and since the ventricular pressure is the active component, then you get some idea of the force development. So when we now look at aortic Doppler, so outflow Doppler profiles, what you see now is that in a normal case, velocities are of course relatively low because there's almost no pressure gradient over the valve. And what you will see is that the peak is early, so you get acceleration, then peaking, and then you get deceleration when the force development goes down. And now with increasing grades of aortic stenosis, so where your aortic valve becomes smaller and smaller and smaller, and so it becomes an obstruction, what you will see is that the velocities will increase. Of course, that's just the law of the kind of the continuity equation, as people say. So that means that the same volume, of course, has to go through because there's no loss of volume. That means that if the diameter of your tube is changing, the velocity has to increase in order to cope with that volume, of course. And that's what you see. So overall, with increasing severity of aortic stenosis, you see that the maximal velocity will increase. And that's what clinicians are using actually also. But what you also see is that even though in these two patients, you have the same maximal velocity, what you see is that the time course is also starting to change. So what you see here is this is again a normal time course, acceleration, And then by 1/3 of the ejection or even earlier, you start to see deceleration. In this case, you see acceleration, and it takes much, much later before the deceleration is started. And the more severe it becomes, what you see is the more rounded it becomes. So you see that not only the maximal velocity will tell you something, but actually also the profile. And we will see, maybe we will discuss that in another session, or when you see like the guidelines on aortic stenosis, what they tell you is you have to measure the maximal velocity, but what they also ask you to do is measure the mean velocity. And obviously in these two, although the maximal velocity is the same, the mean velocity here will be higher than there because of the fact that it stays high much longer. So indirectly, this mean velocity will tell you something about this dynamics. But actually, it's much more interesting, and that's what we are doing in our machine learning projects, for example, is really try to analyze the shape and see whether the shape is changing, and then inferring something about this mechanism of prolonged contraction. Now, this is not only true for aortic stenosis, where you have an increase in pressure or increase in the force that is needed in order to do it. You see the same thing, as we said before also, is either you have an imbalance because of your loading increases, or you can have an imbalance because your contractile force development decreases. And this is actually what you have in coronary artery disease. So here you see two patients, a normal patient, a normal aortic outflow. And this is a patient with severe coronary artery disease, actually like triple vessel coronary artery disease. And again, when you look at the shape here, you see that this one is peaking much, much later and is much rounder. Although when you would look at the maximal velocities, so there's no gradient. And you see here also at some point in a project that was with Zagreb, there was a PhD student that developed this kind of analysis of a simple analysis of looking at the shape in order to try to evaluate this. So you see here is that looking at the dynamics of how force development is taking place will tell you something about the imbalance between loading and contractility. And that's actually what we want to do. And you can infer this, for example, from the velocity trends. You can partially infer this also from strain traces, of course, because as we said last time, when you have acute loading, your strain will decrease, or at least your strain rate will decrease. And if you still have enough time to do the full ejection and have enough time to do the full filling, then of course it might be that your overall strain does not change, but at least your rate of deformation will change. And so looking at this would be similar. Or if you would, for example, take your volume traces over the cardiac cycle, if you would have this dynamics, then you will see also, of course, that that will change. So this information is present in everything that would reflect how the ejection is taking place over the cardiac cycle. But the Doppler is one of the most easy and robust ways in order to look at that, of course. You see that not only in the left ventricle. Here's an example of the tricuspid regurgitation. So that is a reflection of the pressure in the right ventricle. And you see here patients with increased right ventricular pressures and increased pulmonary vascular resistance, for example. And so what you will see here is that you will see that if the right ventricular pressure rises, which is then because of either an increase in resistance of the lungs or an increase in the resistance of the pulmonary valve, for example, with pulmonary stenosis, what you will see is that, again, you might see that it becomes slower and longer, like reflective of, again, this resistance and whether you use this compensatory mechanism in order to do the ejection or not. Okay, here is another example, again, of, in this case, severe increase in right ventricular pressures. And what is actually also nice, and that's why it's also useful not only look at individual traces, but really ideally to have information from both ventricles at the same time and then to time align them. And here you see, when you look at the dynamics of the pulmonary valve, so this is the pulmonary valve outflow versus the aortic valve outflow. So what you clearly see is while the aortic valve here is very normal, so what you see here, and this is one a patient with a pulmonary stenosis, what you see here is that so the pulmonary outflow is very, very late and is actually taking place much, much longer compared to the aorta. Normally, when you have a normal heart, the timing of both ventricles, opening and closures of the valves, is more or less similar. They almost close approximately at the same time. While, of course, when you have a differential loading at one side versus the other, you see that there becomes a difference. So here again, when you do the kind of machine learning, for example, is if we have ways to do this and incorporate this, this would be useful. Now, of course, here it becomes partially tricky in the sense is like, what do you use for timing? Because when we do the learning, we kind of, you need to temporally align, so normalize the time because you use different patients and different things like that. So what do you use for temporal alignment here? Do you use the ejection phase of the left ventricle and aortic valve closure at the left side, or would you use the right side? Because here, if you would normalize this, unless, of course, you take this timing into account, you might get into trouble. And so these are things that are important to keep in mind when you do this type of analysis. But the main thing here is that if you have differential loading, you will have differential dynamics, because partially you will use this development later, but that has an influence on the overall dynamics of the ventricle, of course. Here you see an interesting simulation study, which is partially related to it. So this is with the CircuitApp model of Maastricht, where they looked at pulmonary hypertension and what's going on there. And then they also did some measurements in some patients, or at least another group did, and they compared to it. So what you see now here is that if you start to have more and more pulmonary hypertension, so that means that you have more loading increase at the right ventricle here in this case, what happens is that, of course, the pressure will increase, but what you also see is that the pressure dynamics will change. You see that the peak of the pressure becomes later and later because of the fact that it, of course, is much more difficult to build up a higher pressure given the certain amount of tissue that you have. And very often pulmonary hypertension in patients is developing faster than you could hypertrophy. So what you then get is mostly you get this kind of bulging of the right ventricle. And what you even see here is you see an enormous right ventricle, and you see that the right ventricle is even pushing the septum flat towards the left ventricle because of this very high pressure. And so you see this dynamics. So you see the slow buildup, late peaking, and even in such a way that when you look at the most severe cases where the pressure in the right ventricle is almost the same as in the left ventricle, so you have like pulmonary hypertension at what they call systemic pressures. What you see now is that this force development is taking place much, much longer, and you see even that there's a time period where the pressure of the right ventricle is actually higher than the left ventricle. And this is actually what you see is when you look at this dynamic. So of course, if the pressure at the left side is lower than at the right side, what you start to see, and that's what's happening here, is then the right ventricle is starting to push the septum towards the left side. And so you nicely see this dynamics when you look at the M mode. So you see the normal M mode, you see the contraction of the left, the contraction of the septum. And what you see now is that, and you see here, although it's not that visible, but what you see, this is the inward motion here of the right ventricular free wall. And what you see here is that the right ventricular free wall inward motion is much longer than the left one, because here at this moment, the left ventricle is starting to relax. You see that on the ECG. So you see T wave here. At the end of T wave, you see that the left ventricular free wall is starting to relax. But because of the fact that the pressure in the right ventricle is still high, because of the fact that the right ventricle needs to develop force much, much longer in order to eject at this high pressure, what you now see that, of course, if the left ventricular pressure goes down, you see this inward motion of the right ventricle. And you see here that even if this contraction of the right ventricle is longer, of course, because of this whole inward motion of the septum, it's like the whole thing moves, and it might be that you are not doing a lot of ejection in this period because of this interaction between left and right. So you see that it's really important to understand that physiologically you have this longer force development because that is needed in order to do the ejection, but that has an influence, of course, on how left and right are interacting or how the different timings of the valves are taking place. And you have to take all of these into account in order to understand what's going on in these patients. And just interestingly also, and that's why M modes are actually quite interesting to look at. What you see here, this is actually a patient with pulmonary stenosis, and this is a patient with pulmonary hypertension. So pulmonary hypertension has high right ventricular pressure because of the fact that the resistance of the lungs is increasing and is abnormally high. And we come back to that in another session. Pulmonary stenosis, what happens is that the right ventricular pressures are high because of the fact that the pulmonary valve becomes stenosed and becomes too small. So in total, it could be that the right ventricular pressures are the same in both. So you have pressure loading in the right ventricle because of pulmonary stenosis and also because of pulmonary hypertension. But what you see here is that the dynamics is very, very different. So you see here that in a pulmonary stenosis patient, your right ventricle is not extremely big, while here in this pulmonary hypertension, you see the right ventricle is much, much bigger than the left ventricle. Also, what you see here, and as I said before, is in this pulmonary hypertension one, you see this flattening of the septum predominantly in this early relaxation period. So you really see this fast inward motion when they should be relaxing of the ventricle. You see this inward motion of the septum towards the left. And also when you look at all this dynamics, so you see the septum here is moving very strangely. While in the pulmonary stenosis, what you see, it's almost normal. Normal, what we said before, you have inward motion of the septum, inward motion of the free wall of the left ventricle, also of the right ventricle. And then when you have relaxation, you might have a little bit of post-systolic, if you look at the base of the septum. And that's what you also see in this pulmonary stenosis. You might have a little bit of post-systolic, but not a lot. While here you have post-systolic, but this is not post-systolic contraction, the pulmonary hypertension. This is post-systolic interaction of both ventricles. Now, the reason why, although in the end the resistance and the pressure in the right ventricle are similar in both cases, the reason why the pulmonary stenosis seems to be able to cope with it and the pulmonary hypertension not, is actually that you have to go back in how these conditions arise. Because pulmonary stenosis is very typical a fetal problem. So that means that there's an abnormal development of the pulmonary valve, which makes that your pulmonary valve is too small and you get the stenosis. But that means that the fetus is developing the heart under conditions of high pressures. And what you see now is now you actually have time to compensate for that. So they will have hypertrophy, they will have a very thick wall, but this hypertrophy is sufficient in order to compensate for this loading difference. And in the end, the mechanics are more or less similar. So you have enough force development in order to go against the resistance, and you have a balanced, like normal physiology and so on. On the other hand, pulmonary hypertension is something that mostly develops postnatally and mostly develops rapidly. So that means that during development, this ventricle was not loaded. And also the pressure rise is so fast that there's no time in order to get hypertrophy and to compensate for this. So that means that now you need to use a different method in order to compensate for the loading, which means, of course, dilatation in some ways, or at least trying to become a little bit more spherical in order to lower the wall stresses. The dilatation itself is, of course, not useful, but the dilatation is because of the fact that you get tissue damage. As we said before, when you have the volume loading also with dilatation, at some point, if your wall stresses are too high, you get damage. You need to dilate more in order to compensate. This is partially what happens here. And at the same time, you also use this mechanism for the prolonged contraction or the prolonged force development. So in order to at least be able to do some kind of output. So you really see that depending on the loading type, the dynamics of the loading, when the loading is taking place, whether you have time to do the compensation of hypertrophy, which needs a lot of time in order to of course, you need time to grow more contractile material, or whether you only can use acute mechanisms, which is related to shape changes and which is related to the dynamics of your force development. And so depending on this, although both are pressure loaded ventricles, you see how this pressure loading is being is developed and how you have the time, yes or no, to use one of the different mechanisms that you have for coping. That will depend, of course, how the ventricle will look like. And it's by integrating all this data, looking at what's the etiology, which are the mechanisms which are being used in order to compensate for it, you can try to understand these patients. Here is another one where you have, again, this kind of opposite thing, like if instead of an increase in loading and you can't increase your force development fast enough, you get this imbalance. What you also have is like if your force development decreases with the same loading, you get a similar thing. This is an example, although the images here of the right ventricle are not really great and you can't see too much, but this is a patient with what we call arrhythmogenic right ventricular dysplasia. So this is a genetic mutation of the proteins that are actually interconnecting the different myocytes. And what you get is that actually the right ventricle degrades and you get tissue damage, you get like necrosis and sometimes some kind of fatty replacement. But the main thing is that your overall force development of your right ventricle is decreasing. And so what you see here again, and you nicely see this by looking at the mitral inflow. So we're looking now at the inflow pattern of the left ventricle. And what you see here is that, of course, instead of what you normally would see at the end of T wave, so you would normally find an E wave and then an A wave with contraction, you see you only have one wave here. Right? So this is what we can call like a fused profile. But when you look at the timing, you see that after T wave, there's a whole long period, which would be the isovolumic relaxation time, where there's no inflow whatsoever. So this is a very abnormal inflow pattern in the left ventricle. But the thing is, there's probably not a lot of left ventricular disease. The problem is there's right ventricular disease. And because of the fact that your right ventricle is diseased and is actually using this mechanism for prolonged contraction, because if you have a decreased contractile force development, and the same loading, again, you need to compensate for this. You can compensate for this by longer contracting. What you see there is that in this isovolumic period, and you can see it here in this also the flattening in some ways of the septum. So here actually, instead of that the left ventricle can nicely relax and fill, what happens is that the left ventricular free wall might be relaxing, but the right ventricle, because the pressure is still high, pushes the septum towards the left ventricle so that there's actually no volume change and you don't have inflow. In this patient, actually, this could be corrected in brackets with pacing. And so what you do is if you pace the right ventricle to start contracting much earlier than it normally would, then even if it would contract longer, it would stop contracting or the pressure would go down at the same time as the left ventricle. And you see now that your left ventricular flow is actually normalizing. So you now see a more normal, it's still abnormal relaxation, but you still see there's an E wave and there's an A wave. So it's a big change here. And we haven't changed anything in the left ventricle, but the left ventricular flows are changing because we changed the dynamics of the force development in the right ventricle by making it start earlier. And so in this way, again, by understanding what's the reason why we get these changes and how loading would influence this force development pattern if we can't compensate by hypertrophy, then by integrating this data and potentially then using some ways in order to change this dynamics, that will let us understand potentially also save these patients. Even when we talk about loading is something which is tricky in the sense that loading traditionally would be pressure loading, as we said before. So if you have an increase in pressure and your tissue remains the same, obviously you have a balance and you have an increased load. Okay? Now, the thing is, if your tissue properties are changing, it might also be that you get some loading abnormalities. And here's an example. When we look at this patient, so this is what I told you before already. So you have a normal heart, everything is homogeneous. When you have hypertension, what you see is you start to get an increase in loading or increase in wall stress, which is much more pronounced in the basal septum because of the geometry of the ventricle, and you start to get hypertrophy there. And this is an example of a patient with Marfan syndrome. And Marfan syndrome, what happens is that you have a genetic mutation that actually changes your matrix material. So while traditionally Marfan patients, they have problems with the aorta, and we'll cover that in another session. So they get aortic dilatation because of the fact that their tissue is not as stiff and strong enough as normal, so they get in trouble there later on. What you see actually also is that they seem to be developing signs of pressure loading, which would be this kind of basal septal hypertrophy and actually also post-systolic thickening, while actually they do not have an increase in pressure. So it's really this balance between the pressure loading and how the force development, or sorry, how this pressure, how this loading is translated into wall stress, and how this wall stress will then kind of act on as a trigger for myocytes to become hypertrophic or not. It's in each these components that you can see changes. So it could be that you have abnormal tissue, and because of that you get this. It could be that you have abnormal, in this case, an abnormal matrix, where again, the way that the pressure is being translated into wall stress is changing. All of these things will change how you react to pressure loading. And it's by looking at these different things and trying to find out what's going on that you can actually understand it more. And you see here again, so this is the study in Marfan, where you clearly see that the septum is different, or the base of the septum, predominantly base mid of the septum, is different than all the other kind of segments, while there is not directly a change in pressure, but we know that there's a change in the tissue, or at least in the matrix material. So there's highly likely a change in how the pressure is being translated into the force or the loading or the wall stress on the individual myocytes. And it's actually always this difference between the force development of the myocytes and the loading forces on this myocyte. That difference is going to determine what's going to happen locally. And so you always have to keep that in mind. Now, as last, very briefly, we're going to go in detail there later on also, is then, of course, depending on this loading, depending on the time dynamics of this loading, you will see that, of course, your development can be different. I told you already with pulmonary stenosis, what you see is that you will have the time to actually become hypertrophic, and hypertrophy is the easiest way or the best way to cope with that. If you have more subtle pressure increases in fetal life, as for example, if you have an increased placental resistance, that would lead to what we call intrauterine growth restriction or fetal growth restriction. What you will see there is that the placenta development is abnormal. The placental resistance becomes higher, which means that your pressure in the whole system becomes a little bit higher. And what you see there is that these hearts actually develop a little bit more spherical, because by becoming more spherical, they reduce their wall stresses and would cope with this. But of course, if you develop under pressure loading, you will really change the shape or how the heart is developed. And we can show that actually these babies are born with more spherical hearts, and up to adolescents, at least, they have more spherical hearts. There's a little bit of question what happens later, but again, we will cover this in another session. So you see here that everything is related. So you have loading abnormalities, so increased pressure or decreased force development for whatever reason. This imbalance needs to be compensated. We have acute mechanisms, being a shape change, lowering the wall stresses, or a longer force development, in order to be able to, with kind of the same force development, still develop a lot more power in order to do ejection against the higher pressure. Or if the loading is high enough and long enough or slow enough in order to develop hypertrophy, then that will also be there. And it's the combination of these things that can happen while you see loading. And so then looking at shape changes, for example, the combination of shape changes, the dynamics of the outflow, the thickness of the wall, how the strain is taking place, all of these will tell us one part of the story. And so we can try to see which are the things that are changing. And this is also still quite important at the moment that you're going to look at larger populations versus very specific studies, you will see that this is happening. If you have a very well-controlled population where all of them have the same type of loading for same type of dynamics, then you can do statistics and look at the changes, and there will be predominantly one type of remodeling, or at least one combination, but always the same combination of the different types of remodeling. If you, however, are looking at a much larger population, when you look at a general population study, which of course includes some types of loading, or you're going to look at heart failure patients at much more different ways of doing. For example, typically heart failure with preserved ejection fraction means that very often they fail because of a loading increase. And what you see in these larger populations is that you have these different ways of remodeling, which are actually mixed. And it's up to us to find ways and find technologies, of course, in the future also to try to unravel this. And this will be a combination of looking at shape, but again, shape changes might be different. You have the shape change that will be induced by the acute pressure loading, which happens after your fetal development, or you will have shape changes which are started to be induced in your fetal life. You're born with a different shaped heart. And if then on top of that, you get type of different loading, of course, that will show differently. And so we really have to try to find ways to look at all these isolated or combinations of different mechanisms together. Now, one thing there, and this is kind of speculating also or philosophizing in some ways over things that we will discuss later on also. But if you look at tools in order to do this, one thing would be is that you do statistics or machine learning where you put in the shapes and you put in the traces, the aortic outflow shape, for example, or the volume or strain traces shapes. One thing could be is that you try to recognize the different patterns that are there and then try to infer which one would correspond to what we know of physiology. Or the other thing is, of course, and that's something that in the future we should try to do a little bit more, is that you also put some kind of physiological knowledge there from in the beginning, whether it's either through a computational model that you would incorporate it, or through some typical shape changes or kind of pattern changes that you know are related to one specific type of abnormality or response to, for example, a loading change. So whether we can incorporate these in the beginning rather than post hoc as an analysis. So these are things that I think that the future will still take care of. But the most important to know is that there's different mechanisms in order to cope with this, and that depending on the temporal evolution, depending on the different patient, depending on the conditions, you will see a combination of all these things. And here you see, for example, again, when we look at this fetus with this abnormal placenta, what you start to see there is that you actually in the base of the septum start to see post-systolic thickening when we look at the pattern of deformation. So that means that there is indeed a acute loading at this time. But on the other hand, if we look at the adolescents that were born like this, what we now see is that actually there's post-systolic, here in this case, actually in the free wall instead of in the septum, because this is what you expect, and you partially see here, although not much. You see in controls, if they have a little bit of pressure loading, as we said before, the septum is the flattest, this is where we see the change. But if you're born with a differently shaped heart, it might be that you're differently reacting to, and then later on loading, and that seems to be the case, for example, in this type of patients. So really, looking at one measurement at one time point doesn't tell us everything. We need to keep in mind how this is being developed. And so this is where, as I said before, this whole integration of data is something which is quite important. Okay, I think that's enough for today.